So the story with papillomavirus has many themes that intersect with it. I had one other thing here, if I push the right one. Yeah, which one? Okay. So these are just some of the questions that went through my mind, and I hope as you hear the presentations today, you'll certainly feel free and encouraged to speak up at any time and ask your questions. So one of the things that I wondered was if 50% of women acquire papillomavirus infection within a few years of first intercourse, why is the cancer incidence much less? What's the difference? And what's responsible for the large group differences in the incidence of carcinoma associated with papillomavirus? How is papillomavirus associated with head and neck cancers? How effective is the vaccine? How safe is it? How long is it effective? Why don't we vaccinate males? And why do they recommend vaccinating girls at age 12? Does vaccination reduce the frequency with which women get pap smears? Sexual behavior? Is there any evidence that if a young woman is vaccinated, that she then feels completely uninhibited? What are the national and even international challenges? And as always in medicine, what's next? So we're very fortunate to have two speakers today who deal with, on one hand, particularly the clinical and to some extent the cell biological mechanism of head and neck cancer. That's Carter Van Waes. He received his MD and PhD degree at the University of Chicago, and here at the NIH is the director of the surgery branch of what I refer to as the Dental Institute, because I can't remember what all the craniopharyngeal, right, thank you. and our second speaker is Douglas Lowy, who graduated from New York University Medical School, took training at Stanford, came here to the NIH, has been interested throughout his career in oncogenic viruses. And it's through the work that he and John Schiller and the Cancer Institute that gave rise to the development of the vaccine against human papillomavirus, that form closely related or causative of cancer in men and women, but particularly in women. So we're very grateful for both of you. And in addition, Dr. Van Waes has been to ask one of his patients to come, who has been here once before, and was kind enough to spend his time and tell you his story. So, Carter, would you please begin?
The screen. Okay. I can use those, right? Thank you very much. It's a pleasure to be here today and to share the podium with. Speak a little bit today about an emerging problem that's related to human papillomavirus and getting Jennings Cantrell is going to join us to talk about his experience with head and neck cancer.
Roger, you may have to use this. You're supposed to have another portable one.
Yeah,
Oh, is it on?
I'm on. Can people hear me in the back? No.
No.
Okay.
Maybe you have to hoist it up a little bit.
Let's try that. Can you hear me now?
No.
Can you turn it up or?
Can you turn? Hello.
Are you able to turn up the microphone up? Pardon? Okay.
Here, it's just not loud.
Okay.
Plus, it's going through the webcast, so I don't know.
How is that? Okay. All right, I'll do that. Maybe put that up on the chair for the. So, as I was saying, my patient Jennings Cantrell has been kind enough to join us today, and then Doug Lowy is going to talk about prevention of HPV-related cancers. So the slides are not advancing. There we go. Today I'm going to speak about, just give an overview about human papillomavirus and cancer in the United States. Doug's going to talk about it as a much wider problem as well. And also speak about HPV and other etiologic factors for head and neck cancer, because there may be some exclusive role of HPV and other factors in certain subsets of these cancers, but there also may be some overlap in the susceptibility to these head and neck cancers. And Mr. Cantrell will discuss his case with us. I'll briefly talk about his NIH protocol treatment, although that's not really the focus of the topic today. And then Doug will speak about vaccines. So Doug was kind enough to provide a slide that summarizes the problem in the United States. In the past, HPV was implicated initially in cervical carcinoma in women, and this is now not the only problem in the United States. There's been an increase in the incidence of a number of other sites that have been implicated in HPV-related malignancies, including the vulva and vagina, anus, penis, and more recently, it's become clear in the last decade or so that the oropharynx, which is the part of the head and neck at the back of the mouth where the tonsils lie, right before the pharynx, is also a site for infection and development of cancers that are related to this disease. And in the U.S., it's emerged to be implicated in about 70 to 80% of oropharyngeal cancers, and this has increased over the period of 1988 to 2004 approximately threefold. And this slide just highlights some of the measures of that using samples from tumors that were taken during 4-year windows from over that interval, showing an increase in the, using a standard assay for HPV, using HPV-16 viral load, the E6, E7 marker, which is one of the viral oncogenes, or two of the viral oncogenes and proteins, and in situ hybridization for HPV-16, you can see that over this period, there's been an increase up to the range of about 70% of oropharyngeal squamous cell carcinomas. So another way to look at data across the world, also in this publication from Dr. Chaturvedi, shows that there's also been a trend in developing countries, and particularly in the top panel, panel A, Oropharyngeal cancers are shown in yellow, and then oral cavity and lung cancers are shown in blue and gray. And those are have been associated primarily with the tobacco-related subset of these types of head and neck cancers. And you can see in the developing countries in panel A, for example, that the trend of the gray bars for lung cancer has been declining, whereas the trend in the yellow bars is moving to the right, indicating an increase in prevalence. And this includes, the United States, but also a number of other developing countries. And this is more clear in men because of the divergence in habits related to tobacco use, with a decline in men and the increase in HPV in men. And on the other hand, in women, since the rise of tobacco use has somewhat trailed that of men in the 20th century, that increase is still underway for lung cancer and oral cavity cancer, but also there's an increase in the HPV-related oropharynx cases. So the other etiologic factors that are involved in development of head and neck cancer, and including oropharyngeal cancer, is tobacco use is the other major etiologic agent. And in contrast to most head and neck cancers, where 70% are caused by tobacco and about 30% or 25 or 30% are related to HPV overall, at the site of the oropharynx, it's the other way around. Most of these, 70 to 80%, are related to HPV, and 25% are tobacco-related without evidence for HPV, and another 5% may involve other factors, including hereditary susceptibility, chemical exposure, and radiation. And although we separate these this way for the purpose of defining those which are HPV positive and HPV negative, in fact, many patients who are HPV positive are also tobacco users at some point in their life or have other types of exposure. So it's quite possible that the development of these cancers, which doesn't occur in everyone who's exposed to HPV, may also be associated with additional alterations that occur as a result of their personal exposures. So where does oropharyngeal squamous cell carcinoma arise? So I mentioned that it's associated with the area of the tonsils, and most times when we think of the tonsils, we think about those two large things on either side of the back of our mouth that we see in the mirror. But there are also parts of that you can't see, and those are at the base of the tongue. Those are called the lingual tonsils. And this is the area that our patient was affected by. And also there is tonsillar tissue up in the area of the adenoid in the nasopharynx. And it's interesting that these are the sites in head and neck cancer in which there is a viral etiology. In the adenoid area, Epstein-Barr virus has been implicated in the development of nasopharyngeal carcinomas. And in the case of human papillomavirus, both the palatine tonsils, which are next to the palate, and those that are in the base of the tongue, the lingual tonsils, are associated primarily with HPV-related cancers. However, there has been some recent reports that HPV is also implicated in certain nasopharyngeal cancers, particularly in North America. So this is also a site that may be important for this. And the reason for this may have to do with the structure of the tonsils. To some degree, they have a very thin epithelium in crypts, and this epithelium overlies a lymphoid compartment, which is our immune defenses, and that area may have some type of interaction that precipitates or enhances the infectivity of the virus and its ability to establish itself and perhaps cancer. So we'll now sit down for a few minutes to meet with Mr. Cantrell about his case, and I have some of it summarized up on this slide, which we may both turn to because our memory may not serve us completely in presenting his case, but I'll move over here with him and we'll sit down and talk a little bit about his case presentation.
Make that switch smaller.
Testing. All right. So I'm going to turn this way. So, good afternoon.
Is this working? No? Oh, no. Okay.
I've got nowhere to go. Seems to be. And this was in November of 2008, I think, was when you came to see us. And maybe you could tell everyone a little bit about how long before that you or your wife noticed what was going on and what you thought at the time.
In the summer of 2008, I developed a sore throat, which is unlike any sore throat that I had ever had before. And it was very strange, but, I just didn't make a connection to any kind of serious illness. My wife tells me since then that about 8 to 9 months before that, she had noticed that my breath changed, that the smell of my breath changed, that it developed sort of a musty smell, like the smell of old books. But she thought it was odd, but she didn't make a connection to any kind of serious illness either. So I'm in the catastrophe business, and I found myself working in Nebraska in October of 2008, and while I was there, a node sprang out underneath my jaw, right about here, and I went to a sort of what you might think of as a doc in a box, a little general practitioner that worked out of a little office, and he gave me an antibiotic, and he said, if this doesn't go away in 10 days, you should see an ENT. And so without giving you too much of the play-by-play of how that happened, within the 10 days, it didn't go away. I did see an ENT. He told me I should immediately get a CT scan, and or it was an MRI. I can't remember which one it was. And I did have that test that same afternoon, actually. And he called me the next day at work and said that I had a mass and that he wanted to see me. And I went into his office, and he said that I had a mass which indicated a cancer somewhere in the neighborhood of stage 2 to 3. He didn't know for sure what. And he said he didn't know exactly what it was, but he said it was about an 80% chance that it was squamous cell cancer. So I was on a plane the next day for home, and the day after I arrived, we're talking, again, late October still, because these events are happening. I pushed them along as rapidly as I could, and I saw a head and neck ENT here in Fairfax, and I had the disc that was the image of the test that had been done, and she took a look at it, and she examined me, and she said, what I'm seeing, she used a scope, and don't know the name of it, but I'm sure these folks know what I'm talking about. And she said, I don't see on the scope what I see on the disc, and I don't understand what that is. And she couldn't see anything on the surface of my tongue. And so she scheduled a biopsy, and she performed the biopsy. Turns out that the cancer was in my tongue, could not be seen with the aid of a scope. And apparently she never actually spoke to me about it. She told my wife that I was a stage 4. And she left it to my wife to tell me. and she had some connection here, I believe, with Dr. Van Waes, and so I contacted them, and it turned out that they had a study, a study that involved treatment here, and I came in and saw him, and they decided to accept me in the program, and they began a program of radiology and chemotherapy, which began, I believe, on December 1 of 2008, and I was treated through January 26, 2009, with chemotherapy and radiation. And it was an IMRT machine that they referred to as a TOMO machine, which is apparently more tissue sparing than the standard IMRT machine. And later that year, they found a metastasis in my left lung, a node, and it was removed here at NIH in late September of 2009. And I've had a number of PET scans since then, and biopsies and one thing and another, and it looks as though that I am cancer-free, and I have quite a number of residual problems caused by the treatment, but in view of the fact that I'm still here, I feel that it's probably a good idea to view those in a somewhat philosophic way.
So, thanks. In terms of what you think may have been some of the things you were exposed to or may have caused this, what are some of the things you had told us at the time that you remember?
Well, I served in Vietnam and was exposed to Agent Orange. There were, I occasionally smoked a pipe or a cigar, and when I say occasionally, I mean it was not uncommon for me to go 6 months without smoking a pipe or a cigar. So occasional in my case means very occasional. I never smoked cigarettes ever in my life. So those and normal living are what I would guess the possible agents of causation are.
Mm-hmm. So you had also had an HPV test done on the tumor specimen when you had the outside evaluation?
Yes, the ENT that I saw here when I got back to Fairfax did, as part of her examination of me, a test for HPV, and it was negative. And so she, when she told my wife about the stage 4, she said, "Well, of course, if he had been positive for the HPV, he would have a higher likelihood of being cured or achieving a status of no further cancer, because, of course, using the word cure is a serious no-no, apparently." But she said he's negative for HPV, so we can't count on that.
Okay. So I think with that, I'll go ahead and go back up and tell the rest of the story and a little bit about, yeah, oh, sure.
Does anyone have any questions? Yes, sir.
Were you actually negative?
Apparently. I never had anyone say that. It is true that when I was younger, my wife used to complain that my snoring rattled the windows, literally. But in later years, last 25, 30 years, that problem diminished and went away. So no one has suggested that that was a cause.
So, so that's where we left things. This was at least by the outside scan and the biopsy, it appeared to be a stage. The primary site size of this tumor was what we call a T2 on a scale of 4, and the having a neck node and also on scan having more than one node, one on one side and one on the other, it was called an N2C.
You can only have one at a time.
Okay. All right, there we go. At that time, there was also no evidence that this had spread anywhere else beyond the head and the neck region. So when he was scanned here a month later, pretty much the same story, although there were multiple lymph nodes in the neck, and this tumor was actually fairly large. It extended across the back of the tongue from one side across the midline. And in terms of how that has implications for therapy, the back of the tongue is a fairly unforgiving area for surgical treatment when it goes across more than half of the tongue and really requires removal of the whole tongue and leaves people basically crippled in terms of their speech. So over the last 20 years or so, the treatment of combining chemotherapy or drug treatment with radiation has evolved and has been shown to be fairly active in this area. In part, we're learning now, perhaps because these are HPV-related cancers. And so he underwent treatment with an investigational regimen which combined two drugs, one called bortezomib and another called cetuximab, which is an antibody therapy, with the radiation therapy. And I'll give a little bit of background for the rationale of that, but not dwell on it. So cetuximab is an antibody therapy that was first developed from an antibody that was found in the 1980s to block the epidermal growth factor receptor, which is seen in the upper right-hand corner there on the cell surface. And the epidermal growth factor receptor is an important growth signal for head and neck and other epithelial cancers, and it signals into the cell through a number of pathways, including the mitogen-activated protein kinase and the phosphatidylinositol 3-kinase pathways. And in these cancers, the role of inflammation, I mentioned to you earlier that these cancers have, that they develop in lymphoid-type tissue in the base of the tongue and the tonsils, and they also appear to have fairly strong signals of a number of different cytokines that also signal to activate downstream pathways, including the NF-kappa B pathway. So the two drugs that were used in this study were designed to target, with bortezomib, the NF-kappa B pathway and its activation, and EGF and its downstream pathways using cetuximab, and radiation to activate the P53 family, which is involved in inducing cell death and is also inhibitory for growth. And this is just a number of the target genes, but the objective of these drugs was to inhibit the phenotype or the cancer cell is proliferation, survival of the cells, and the blood vessel formation and inflammation. So the study design was to give the cetuximab drug weekly and to give the bortezomib twice weekly for 3 weeks with time off in between of 1 week. And this was combined during the time of radiation therapy. And this was reported as a study was reported in Clinical Cancer Research in 2011. So the outcome in Mr. Cantrell's case is that he had CT scans 3 months after treatment that showed a complete response or elimination of this mass in the base of his tongue, which we could also see both in the clinic and in the operating room endoscopically, and a biopsy of that area didn't show any sign of cancer left at that site. And so he was considered a complete response at that point. But only a few months later, He had a new lung nodule which had not been seen up to that time, and this was resected by our thoracic surgeons here as a single nodule. And this showed a poorly differentiated squamous cell carcinoma that was very similar to the one in the back of his tongue. And what was interesting about this was we asked them to stain it for a marker, which is a marker that is usually increased in HPV-positive cancers, and this came up positive for P16, which is a marker that's consistent with an HPV-positive primary tongue tumor. Mr. Cantrell is now approaching 5 years of disease-free survival from the time of his last treatment. So what we learned about oropharyngeal squamous cell carcinoma, particularly HPV oropharyngeal squamous cell carcinoma, is that it is a different disease from the tobacco-related cancers, which have a much worse prognosis. One of the important differences, also highlighted in the same article we were talking about earlier and we're picking back up on again, is that the median survival is much closer to 5 years for half the patients surviving 5 years or longer, compared with 2 years for the tobacco-related malignancies. And again, this improvement in survival in oropharyngeal cancer has trended over the years to occur in patients in the same interval in which we've seen this increase in HPV positivity in oropharyngeal carcinomas in place of tobacco-related oropharyngeal carcinomas. So I'm going to end my talk just by talking a little bit about some of the emerging data that we're getting from the new Cancer Genome Atlas initiative, in which almost 300 head and neck cancers have now been sequenced using the next generation sequencing technology. And it's allowed us to make a roadmap or a circuit diagram of the types of alterations in these different cancers. And for human papillomavirus related subset of these cancers, what we know is that the virus serves as one of the key, its oncoproteins, E6 and E7, inactivate a couple of the tumor suppressor genes that are important in this type of cancer, both P53 and RB. And in addition to that, as a result of that, these cancers have a different genetic alteration than the tobacco-related malignancies, which in most cases result in inactivation of an upstream cyclin-dependent kinase, which is the gene that encodes P16. So those patients who have HPV-related cancers tend to have high P16 in most cases. As well, these cancers show much fewer other genetic alterations than the tobacco-related malignancies, which have genetic alterations in most of these other molecules. But in HPV, there appear to be, in these cancers, a much more focused alteration in the PI3 kinase catalytic subunit, which is affected in about 60% of these cancers. And also the P63, another P53 family member, this gene is amplified along with PI3 kinase in about 30% of these cancers, and mutated additional mutations in another 30% in the PI3 kinase catalytic subunit. And so across these pathways, pathways involved in cell growth, cell survival and death, immunity, and in differentiation appear to be affected by genetic alterations. And one of the ones that's particularly noteworthy in those that in the HPV positive cancers is a loss of a gene called TRAF3, either loss or mutation. And this occurs in about 1/5 of the HPV-related cancers, but not in the tobacco-related malignancies. And this is of particular interest because TRAF3 is not only a negative regulator for NF-kappa B, which is one of the transcription factors that activates many genes involved in proliferation, cell survival, inflammation, angiogenesis, but it's also a protein that's involved in inducing interferon response factors and interferons, which are involved in the immunity to DNA viruses. So we think this may be one of the important events that differentiates HPV-positive cancers from tobacco-related cancers. So in terms of our therapies, we've known for many years that cisplatin is an active agent in head and neck cancer, and particularly in HPV-related oropharyngeal carcinomas in combination with radiation. And these two standard therapies appear to have some of their effects, in addition to their DNA-damaging effects on cell proliferation, also appear to cause the degradation of one of those oncoproteins, P63, and also because these HPV-related cancers may have some residual P53, it may be that radiation is effective through the leakiness of the viral oncoproteins, incomplete inhibition of P53 in these tumors. In addition, now with the emergence of our knowledge about PI3 kinase, it may be possible to target these cancers with PI3K inhibitors and perhaps reduce the need for some of the more toxic agents which we use currently for this type of cancer. So in summary, HPV-positive oropharyngeal head and neck cancer is increasing in the U.S. and worldwide. These cancers are associated with improved survival, and they have fewer genomic alterations than HPV-negative squamous cell carcinomas. And one of the markers for this we can use clinically is the retention of P16. And because they have decreased but not mutant P53, in contrast to the tobacco-related malignancies, they may have a greater maybe one of the contributing factors to their greater responsiveness to our standard therapies. And what we're learning about the alterations specifically affecting these cancers in the cell cycle, PI3 kinase, and the TRAF3 NF-kappa B and interferon pathways may define some new potential targets for prevention as well as therapy. So are there any questions related to that?
Thank you very much. Well, folks are thinking of the same pathways involved in HPV-related tumors in the cervix and other organs, the general.
In terms of the overall genomic alterations between the two cancers, particularly the HPV subset of head and neck and cervical cancer, it doesn't appear that TRAF3 loss is as common in cervical from what we know from.
So the therapies are somewhat similar? Yeah. Any questions? All right. Well, we will continue. Thank you.
Well, good afternoon, everyone. It's really a pleasure and an honor to have been invited and also to be able to participate with Dr. Van Waes and with Mr. Cantrell. You've really heard, I think, a very good introduction as well as a striking example of how improved treatment can actually help patients and in addition can also improve quality of life. Mr. Cantrell didn't disclose to us exactly what his side effects were, but I think it was instructive that the extensiveness of his cancer led actually to a decision to do chemotherapy plus radiation rather than surgery in order to try to preserve his ability to speak, etc. I am going to continue and to switch gears a bit to really try to talk more in the prevention area than in the therapeutic area, but also to try to address some, although perhaps not all, of the questions that Wynn was asking at the beginning. First, a little bit of housekeeping, disclosures. I have been involved in the development of the licensed vaccines, and our technology has been licensed to the two companies that make the vaccines, and I will discuss potential off-label use of the two FDA-approved vaccines. What I'm going to talk about is go back briefly over the notion of HPV infection and disease, and then talk about prevention both by screening and vaccination. And then after we talk about that a bit, to move to HPV-based screening and to fewer than 3 vaccine doses, which is what the vaccines have been approved for up to now, and then end with a little bit about second-generation vaccines. And as Wynn mentioned, I've worked very closely with John Schiller now for close to 30 years, and we've had wonderful collaborators both within the laboratory, within the NIH, extramurally, and importantly, internationally. The implications of identifying HPV as the main cause of cervical cancer have really been profound, and even Harvey Alter would approve, I think. The identification by Harold Zerhausen and his colleagues of HPV 16 and 18 in the 1980s led finally to his receiving a Nobel Prize 25 years after the discovery of these two viruses. And as with any other infectious agent that is the cause of an important disease, you hope that the discovery of the agent will lead to targeted interventions against the agent, because in principle that might be easier than trying to develop treatment that is specifically targeted to the disease. And I must confess that what Dr. Van Waes was talking about for Mr. Cantrell is really trying to target the disease as opposed to targeting the HPV in the disease. In this situation, of course, since there wasn't an obvious presence of HPV, the option didn't seem to be there anyway, and we don't have any approved treatments against HPV encoded proteins, for example, for these cancers. But this identification led to an explosion in understanding the natural history of HPV infection, the pathogenesis of cervical cancer, and ultimately to the pathogenesis of other cancers. But the identification of other HPV-associated cancers is a direct outcome of the identification of the virus. For example, we didn't really understand that HPV might be an important cause of oropharynx cancer prior to the discovery of HPV. So first, in terms of disease understanding, it's very important. The next aspect was the spectrum of disease, and I'm going to contrast what I'm showing you here on this slide with the next slide, which is what Dr. Van Waes showed you in the United States. HPV infects a high percentage of people who are sexually active, but in the developing world, it mainly causes cervical cancer, and I'll explain why in a little bit. And this profile shows you the number of cases of cervical cancer that occur in the developing world, about 500,000 cases per year. And the other HPV-associated cancers are much less common in the developing world. And to put this in perspective, about more than 90% of HPV-associated cancer is cervical cancer. And globally, about 85% of those cancers occur in the developing world, and about 88% of the deaths. So that from a global perspective, cervical cancer is the #1 problem, and it is a particular problem in the developing world. And in many countries in the developing world, cervical cancer is the most common cancer of women. And it's a particular problem because it tends to strike women who still are raising children, et cetera, rather than occurring in women who are grandparents, et cetera. If you contrast that profile with what is seen in the United States, you can appreciate that the other cancers, the non-cervical cancers, are approximately as numerous as the cervical cancers. These white areas are the cancers of these types that are not HPV associated. Another important difference is that while in the developing world, approximately 95% of HPV-associated cancers occur in women, in the United States, it's more like 70% or so occur in women. So that on the order of 3 out of 10 HPV-associated cancers in the United States are occurring in men. So this is another clear difference. And oropharynx cancer, as Dr. Van Waes had mentioned, the incidence has increased substantially over the last 25 years, and it is predominantly males who develop this disease, about a 3-to-1 ratio of males to females developing this disease. Thus far, cervical cancer still occurs only in women, even in the United States. I'm sorry, that was a joke. When asked at the beginning if HPV infection is so common in women, why is cervical cancer relatively uncommon? And first, I would point out that our estimates now are that probably 75 to 80% of women will have at least one genital HPV infection during their lifetime. So it's a very common infection, and it's almost always going to be a sexually transmitted infection. Luckily, the vast majority of both men and women who are infected by HPV, the infection is self-limited, which means that after a period usually of between 6 months and 2 years, the infection goes away spontaneously. However, there is a subset of individuals in whom, instead of going away, the infection persists. And persistent infection is a major risk factor for the development of HPV-associated cancer, whether it is cervical cancer or oropharynx cancer or any of the other cancers. And what this shows here is that you can have spontaneous regression, and subclinical infection is much more common in the US than cancer. Part of the decrease here is because we have effective screening. Pap smear screening was developed approximately 60 years ago and has had a big increase in reducing, in reducing the incidence and mortality from cervical cancer. And I have a slide for that later. But there are still about 12,000 cases per year in the United States. Another advance that is attributable to the discovery of HPV as the causative agent of cervical cancer and then of these other cancers is the development of HPV-based cervical screening and HPV interventions of the preventive vaccine, and theoretically development of therapeutic vaccines or antivirals. But there has been less activity in these areas. I would point out that in addition to hepatitis B virus, where there's preventive vaccination, and with HPV, hepatitis C virus is also an important cause of liver cancer and becoming progressively more important in the United States. And there have recently been major advances in the effectiveness of the antiviral treatment of HCV infection. And so we hope that the incidence of serious cirrhosis, liver failure, and liver cancer attributable to HCV infection will go down over time as more people are able to be treated. With HCV infection, the protective immune responses are not well understood, and so it has turned out to be easier to develop antivirals against HCV infection than to develop a primary preventive vaccine. I just want to point out that the way that cervical HPV-based screening is done in the United States is in conjunction with cytology. But it's used as a primary screening test in some countries. And 2 weeks ago, the FDA Advisory Committee said that the Roche test can be used for primary screening. This is the COBAS test. These are different FDA-approved tests. So I think that primary HPV-based screening is coming to the U.S. And will probably be available quite shortly. And I'll explain to you part of the reason. This looks at the incidence of cervical cancer over the last 40 years. And what I hope you can appreciate is that there's both squamous cell cancer and adenocarcinoma. And the decreased incidence is really primarily attributable to the decrease in squamous cell carcinoma, less so with adenocarcinoma. Cytology is a much better screening test for squamous cell cancer than for adenocarcinoma. And the advent of HPV-based screening can improve the recognition or the detection of the incipient lesions that may go and progress to adenocarcinoma. And so we're hoping that the use of HPV testing not only will be able to continue this downward cycle here for squamous cell carcinoma, but also to have an impact on the incidence and ultimately the mortality from adenocarcinoma. It's really important to understand that although the hepatitis B virus vaccine was first introduced in the 1980s, the evidence for reduction of liver cancer is quite limited up to this time because there's such a long interval between the time of the infection and the development of the cancer that you are trying to prevent. And the situation is very similar with HPV to the extent that you're trying to prevent cancer. HPV infection also leads to some non-malignant infection, for example, genital warts, and there the impact can be seen much faster. But we have two modalities of trying to prevent cancer. One is screening and the other is vaccination. And I have this slide here to try to impress on you that actually there are some theoretical advantages of screening compared to vaccination. And that is, in principle, you could have an impact on reducing incidence and mortality attributable to cancer much faster if you do screening than if you do vaccination, because vaccination is preventing the initial infection. Whereas screening, you already have the initial infection, it's gone on for some period of time, and you then are identifying the precancers, and this then leads to the reduction in cancer. So while vaccination may be as efficient as screening, it takes longer to see the impact if the endpoint that you're looking for is a reduction of cancer or a reduction in mortality attributable to cancer. And this shows you the results of a randomized controlled trial of screening that was carried out in rural India and reported about 4 years ago. It was sponsored by the International Agency for Research on Cancer, which is an arm of the World Health Organization. And what I would hope you will see here is that this is looking at the mortality rate of the women who were in the trial. The women were of age between 30 and 59. They were screened once and then followed up based on the results of the screen. These are the women who received HPV-based testing. The other women in the other groups were either essentially a standard control group, cytology, or what's called visual inspection with acetic acid, which very recently has been shown to have some impact. But for cytology and VIA to have impact, you need to do several rounds of screening, which logistically is often very difficult in resource-poor areas. HPV-based screening, however, is sufficiently sensitive that it was able to have an impact on mortality within less than 10 years. So I just want to make sure that we all understand that screening has real potential utility. I now want to turn to the issue of primary HPV vaccination. And the licensed vaccines against microbial agents are mainly preventive, and the induction of what are called neutralizing antibodies tends to be critical. Neutralizing antibodies are the antibodies that interfere with the ability of the agent to be infectious for the host. And HPVs contain viral oncogenes. You already heard from Dr. von Waes about E6 and E7. E5 is another one. And since preventive vaccines are given to normal populations, the notion was that you probably would not want to be giving oncogenes to normal populations. And so a subunit vaccine lacking these oncogenes probably made more sense if it could be successful. And papillomaviruses encode two proteins that induce neutralizing antibodies, which are the two capsid proteins. The capsid is the virus particle and is composed of two proteins, L1 and L2. L1 contains what are called the immunodominant neutralization epitopes. What this means is that if you immunize with the virus particle, the main neutralizing antibodies are directed against L1, and they are conformationally dependent, which means they assume some kind of native structure rather than their linear extended structure. And the key hypothesis was that L1 could self-assemble to make empty particles, having a conformation that induces high levels of neutralizing antibodies. And that indeed was the case. This is a picture of HPV-16 virus-like particles made in insect cells by infecting them with a recombinant baculovirus that expresses L1. And they assemble spontaneously into these particles, and the particles have what seems to be the arrangement and conformation of authentic virus particles, except that they are devoid of the viral genome, and they're able to induce high titers of neutralizing antibodies. They're non-infectious and non-oncogenic. There are two commercial HPV vaccines, one Gardasil made by Merck and the other Cervarix made by GlaxoSmithKline. The GlaxoSmithKline vaccine is a bivalent vaccine. It uses virus-like particles from HPV-16 and 18. And together, we think that they account for about 70% of cervical cancer and an even higher percentage of the non-cervical cancers. The Merck vaccine, in addition to having particles for HPV 16 and 18, also have particles for HPV 6 and 11. And together, HPV 6 and 11 account for about 90% of genital warts. And I want you to remember that because I'm going to show you a slide about the impact in Australia on the incidence of genital warts in the last few years since the introduction of the vaccine. I would point out that both vaccines are given in intramuscular injections over 6 months. The adjuvant that is used by GlaxoSmithKline is a proprietary adjuvant called AS04, and it's a little bit more immunogenic than the alum adjuvant that is used in the Merck vaccine. And I just want you to be aware that there are some differences. In the United States and most places in the world, the Merck vaccine dominates in terms of market share. And the reason for that is that the Merck vaccine was approved in 2006, whereas the GSK vaccine wasn't approved until 2009. So that accounts for it. And one of the other questions that Wynn was asking about was, what about safety? Okay, I have another slide that discusses this from a sociological perspective, but this is to try to discuss it from a scientific and evidence-based perspective. The Centers for Disease Control has a passive reporting system called the Vaccine Adverse Events Reporting System. And after the first few years of the introduction of the vaccine, there were thousands of reports that came into the VAERS of different kinds of side effects, and there was a highly publicized paper that was published in the Journal of the American Medical Association 5 years ago that identified these various potential side effects as being vaccine associated. What the CDC and the FDA do is that they follow up the VAERS result with what is known as the VSD, which is the vaccine safety data link. And this is a prospective study from several managed care organizations that looks at what the side effects are associated with a number of doses. The principal difference between the VAERS and the VSD is the VAERS is anecdote. There is no denominator. It just gives you a certain number of cases. The VSD is evidence because it has both a numerator and a denominator. It tells you the frequency of side effects for a certain number of doses, and it has comparators. And there's no vaccine-related increased risk to pre-specified outcomes in this study from 2011. And it was recently updated with 1.5 million doses presented at the Advisory Committee on Immunization Practices last year. The rate of anaphylaxis is similar to that of other vaccines, and the rate of fainting is similar to that of other adolescent vaccines. How about efficacy? In black is the efficacy for the Merck vaccine, and in orange is the efficacy for the GSK vaccine. And this is in the group of young women who were 16 to 23 at the time of vaccination, who during the vaccination period were virus negative and were antibody negative. This is the group that is closest to the group of the target group that you want to vaccinate, because you want to vaccinate people who are not yet sexually active. But in order to do the trial was conducted in women who had had a limited number of sexual partners but were sexually active. And when looking at this subgroup of women, the vaccine efficacy is over 90% and is close to 100%. For the Merck vaccine, there are numerous clinical endpoints that were used: moderate and high-grade cervical intraepithelial neoplasia, which is pre-cancer essentially, pre-cancer for vulvar and vaginal neoplasia, and for the Merck vaccine also genital warts. And the Merck vaccine is approved by the FDA for all of these indications. The GSK vaccine was analyzed for a more limited number of outcomes just for cervical precancer, and again had a performance that was very similar to that of the Merck vaccine, but it is only approved for prevention of cervical cancer, not for the others. However, part of my not off-label use, but at least mentioning, there's every reason to believe that the GSK vaccine would be just as efficacious in preventing infection and disease at the other sites. However, you would not expect it to be as efficacious against genital warts, and the data actually support that, although I'm not going to present that, because the GSK vaccine doesn't really doesn't target HPV 6 and 11. So what are the goals of vaccination? Most people think about the goals of vaccination being primarily to reduce the risk of infection and disease in vaccinees. And while that is critically important, in my opinion, especially when it comes to HPV vaccination, that's just one of the goals. I think that there is also a second goal, and that is to indirectly reduce the risks of infection by reducing the prevalence of the HPV vaccine types in the general population, which is known as herd immunity. One of the features of the HPV vaccine is that neither vaccine is approved for prevention of oropharynx cancer. And the principal reason for that is that in contrast to the precancers that occur in the anal canal, in vulvar vaginal, and at the cervix, there is not a well-recognized precancerous lesion in the oropharynx. And therefore, you don't have that disease to follow to see if you actually prevent it. So the best that we can do is to show that you can reduce the risk of HPV infection in the mouth. And the relationship between HPV infection in the mouth and the development of oropharynx cancer is more tenuous than the relationship between the precancers in the genital tract and the development of cancer. And so it's not approved for that. But in my opinion, there is every reason to expect that if you reduce the prevalence of the HPV, you will reduce exposure, and it's really almost impossible to imagine a scenario. If you reduce exposure, you will reduce the incidence of this disease. So I actually think that both of these are important. Now, here are two slides of genital warts in Australia. In Australia, as I'll show you in a few slides, was an early adopter country and a relatively high rate of HPV vaccination among young women. And if you look in blue, this dotted line shows you when the vaccine was initiated in 2007, and the incidence of genital warts among young women who were less than 21 years of age went down dramatically in the ensuing 4 years. If you look in red, this is in the women 21 to 30, and many of these women were vaccinated. The women over 30 were not vaccinated, and you can see that the incidence of genital warts did not go down in those unvaccinated women. Even more impressive are the data in the males, because during this time period, males were not vaccinated. They recently have initiated vaccination of males, but these data are compiled before male vaccination was initiated, and this is strong evidence of herd immunity. Once again, looking in blue, these are the men who are under 21, you can appreciate that their incidence of genital warts went down dramatically, although not to the same degree as the women. And the same thing is true for the men who were 21 to 30, and no statistically significant change in the men who are over 30. So I want to spend a couple of minutes asking and trying to address the question, why is the vaccine so effective? There was understandably great skepticism about the ability of systemic immunization with a protein-based vaccine to be able to reduce infection and disease that is caused by a local mucosal infection, because the principal target was cervical infection, and cervical infection is a local mucosal infection. And so we think that there are sort of like three reasons. The first is the repetitive structure of the virus-like particle immunogen is intrinsically immunogenic. And this is something that has become more widely recognized in the research community over the last few years. And actually, in June, there's going to be the second international conference on virus-like particle and nanoparticle vaccines because of their immunogenicity. And a small advertisement for my partner in crime, John Schiller, is going to be giving the keynote address at that meeting. A second reason is that the tissue-associated neutralizing antibodies are exudated at potential sites of infection. What that means is that the antibody levels at these sites reflect their level in serum rather than their lower level in the non-disrupted genital tract. And I'll show you pictures about that in the next two slides. And then finally, HPV is highly susceptible to neutralizing antibodies. So this slide shows you that in our mouse model of HPV infection, the first step in HPV infection is actually binding to the basement membrane that separates the epithelium from the dermis. And this requires trauma, microtrauma, in order for there to be binding. HPV doesn't bind to the apical surface, that is the upper surface of epithelial cells, even the columnar epithelium of the cervical canal. But it binds very avidly to these areas, and it initiates its life cycle while still on the basement membrane, and then only later transfers to the target epithelial cell. Now, this cartoon essentially shows you what happens in an immunized individual. There are low levels of antibody in the cervical canal, but higher levels reflective of what's in the serum that's in the tissue. But at the points of potential infection, the barrier function of the epithelium is disrupted, and so you get the antibodies going into this area of potential infection. And so when the virus particle comes in, the antibodies actually recognize the particle, bind to it, and interfere with the ability of the virus to bind to the basement membrane. And even at low levels, we see binding to the basement membrane, but you don't get the transfer of the virus to the target epithelial cell. So there are two different mechanisms there. Now, I want to say a few things about, if you will, uptake of the HPV vaccine, and there are major differences depending on the country where you are. And in red are shown 1 dose, and in blue are shown 3 doses. In the United Kingdom, which has school-based vaccination, you can appreciate that probably 90% are fully vaccinated. In Australia, the number that are fully vaccinated is a little bit lower, but still a high number. A high number. The United States, however, we are substantially lower, and so you can expect that the impact from the vaccine is going to be less. And just so I didn't want people to think that we're last. France, the uptake is even lower. So the uptake of the vaccine in the United States, there are several reasons, but I've outlined a few of them here. One is medical uncertainties at the time of FDA approval. Safety, duration of protection, for example, were key issues. These issues have largely been addressed positively subsequently to the extent that they can be. Since the vaccine has been in use for really only 7 or 8 years, you don't have duration of efficacy much beyond that. But thus far, it seems to be fine, and I mentioned the safety data. Provider hesitancy is something that the Centers for Disease Control identified as a major issue, which is a lack of strong vaccine recommendation from healthcare workers in the United States. There also was pushback from efforts to make the vaccine mandatory in 2007, which was the year after it was approved. And for those of you who have long enough memories back to the Republican presidential debates, Governor Perry got into some issues with the question of trying to make the vaccine mandatory in Texas. And then there have been concerns about vaccination promoting sexual disinhibition, which has also had an impact. I just want to show you 2 slides that sort of contrast or compare what the story is with cervical cancer incidence and mortality in the United States, because it really is quite regional, and to see what happens with vaccine impact. This is in red are high incidence, okay? This is not the Republican states, okay? And these are not the Democratic states. But even the Republican states that are located here would probably rather be blue when it comes to cervical cancer incidence and mortality. And but I want you to look at the distribution here, and here is the vaccine uptake as of 2011. And here, the darker purples are the places with more vaccination, and the lighter areas are places with less. And in general, the areas that have the biggest problem with cervical cancer are the areas that the vaccine has been underutilized. So now I want to talk a little bit what's being done that might change this, other than people yelling and screaming or whatever. So this is going to be largely science-based, okay? One thing is, as Wynn mentioned, what about the vectors? What about males? Sorry. That was me who said, what about the vector? And so Merck did some less intensive studies of males and showed that the vaccine is also protective against males, both against genital warts as well as against anal dysplasia. And the FDA gave approval for males, both for warts and the prevention of anal cancer. And this led the CDC Advisory Committee on Immunization Practices in 2011 to make the same recommendation for boys as for girls. I just want to point out the Merck vaccine is approved for both genders, the GSK vaccine only for girls. Once again, off-label. There is no reason to believe that the GSK vaccine would be less effective in males, but efficacy has not been tested in males. So that's one potential way of trying to increase the uptake. Second is, would fewer than 3 doses be protective? So these data are taken from the National Cancer Institute has been conducting a trial of the GSK vaccine in Costa Rica, where cervical cancer traditionally has been the most common cancer of women in Costa Rica. And some of the women instead of getting all 3 doses, only got 1 or 2 doses. And we were able to then look at the attack rate for the women who got only 1 or 2 doses. And before looking at the vaccinated group, look at the control group. The control group for 3 doses, the rate of HPV-16 infection per 100 women was approximately 8% here, 6% with 2 doses, and 8% with 1 dose. So there didn't seem to be any behavioral difference. And remember, this is a randomized, double-blinded trial. So neither the women nor the people doing the exam know who got which, whether they were in the control group or in the vaccinated group, the HPV vaccinated group. And you can appreciate that the rate of protection, the vaccine efficacy for 2 and 1 doses is as great as for vaccine efficacy for 3 doses. And I would like to say that for 2 vaccine doses, the future is now. But the future is now outside the United States. The initial regulatory approval for 3 doses in girls was what was called on the basis of what's called non-inferiority bridging. What that means is that the younger adolescents were approved not because of efficacy, but because their immune response to 3 doses was not inferior to the immune response of the young women who were in the trials where the good efficacy was shown. But those studies showed that the young adolescents actually mounted a stronger immune response than the older adolescents who were in the clinical trials. And so the notion of could you get away with 2 doses instead of 3 was essentially advanced. And 2 doses separated by 6 months produce an immune response similar to those in the responses to 3 doses in the efficacy trials. And there was a positive opinion from the European Medicines Agency, which is like the European FDA, Committee for Medical Products for Human Use, for 2 doses for both of the vaccines. And in December, they approved the GSK vaccine for 2 doses in young girls 9 to 14 years of age. And last month, the committee recommended the Merck vaccine for 2 doses in girls and boys 9 to 13. The EMA has not yet approved it, but approval is anticipated. But I just want to repeat that in the United States, the recommendation is for 3 doses. My expectation is that 5 years from now, we'll also be at 2 doses, but we're not there now. These are the immunogenicity studies of the Costa Rica trial whose vaccine efficacy results I showed you a few minutes ago. And what I want you to see is not just the results for 2 and 3 doses, where it's quite similar between 2 and 3 doses, but with 1 dose, note that the antibody levels don't go down over time. This is a totally unexpected result. Protein-based subunit vaccines, almost always you need to be boosted. You know, the classic is the tetanus toxoid. And, you know, we all know that every few years, you know, you haven't had your tetanus shot, you got to get it again, okay? So this vaccine is analogous in the sense that it is a protein-based vaccine. We think that the stable antibody titers may be attributable to 2 factors. One is that the particles are highly immunogenic, as I mentioned, and the other is that the GSK adjuvant includes what's called a TLR4 agonist, which activates another activator of the immune system in addition to alum. And we don't know whether there are implications for other vaccines. Possibly there might be a randomized controlled trial to rigorously test the efficacy of 1 dose. Since this is contrary to expectation and this was not a pre-specified primary outcome of the trial, you really need to do a rigorous randomized control trial before you would accept that one dose would be useful. I now want to get to the last topic of the talk, which is second-generation vaccines. I have about 4 slides. And the goal would be either to make broader protection or less expensive. And one thing you could do is to simplify vaccine production or administration. The measles vaccine, for example, it's an RNA virus, but there's excess coding capacity in the vaccine. And you can actually encode L1 for HPV-16 and express L1 in measles vaccine. And at least in mice, it induces high levels of neutralizing antibodies. And you could just incorporate that, and you could then get your first dose at least with measles vaccine. More closer to home is that broadening protection against more HPV types, because I'm going to show you some preliminary data from a new candidate vaccine produced by Merck. It could prevent a higher proportion of HPV infections and increase broader protection, could reduce the cost of screening because there would be fewer positive tests, and you might be able to lengthen the screening interval, and it might lead to increased vaccine uptake. So this diagrammatically shows you what the current vaccines do, that they can prevent about 70% of cervical cancer. And what Merck has done is to add the next 5 most common oncogenic HPV types in terms of causing cervical cancer. And this, this can prevent, in principle, close to 90% of serious cervical infections. I point out that it's not all of them, but it's the vast majority. And they have recently presented their results in abstract form at a couple of research conferences. And so this tells you that this 9-valent vaccine is called V503, adds these HPV types, and they did a clinical trial that the control group actually received Gardasil, the quadrivalent vaccine, and the primary endpoint was moderate cervical intraepithelial neoplasia, that's moderate dysplasia, against the 5 new HPV types, and immunological non-inferiority against the other 4 types. And the vaccine efficacy against the 5 new types was 96%, and the protection against persistent infection was, by those types, was also 96%. So this was 1 case in the V503 group versus 27 cases in the quadrivalent group. And you can look online for if you want more information. It has not yet been It has not yet been published. This is taken from a natural history study in Denmark, looking at women who have had their first screening test for cervical cancer in their early 20s, and they've had one positive test, or in the case of this orange line, a negative test, and they're followed up then in the system for the next 12 years to see what happens. So these are women who are HPV-16 positive, and they are cytologically normal. They have a pap smear at this time period, and then they're followed. And what I hope you can appreciate is that more than 1 in 4 of them develop high-grade dysplasia or invasive cancer over the next 12 years. There's an intermediate group composed of HPV 18, 31, and 33, and there, over the next 12 years, it's about 15% of them develop high-grade dysplasia or worse. And then in blue are there's a cocktail of 13 different HPV types, which is one of the FDA-approved tests, but it's been fractionated so that you exclude these 4 types. And you can see that the rate of development of high-grade dysplasia over the next 12 years is very low, and a little bit higher than that of the women who are negative. I'm showing you this because I think that, since these 4 types are all in the 9-valent vaccine, if the 9-valent vaccine were approved by the FDA and were widely used, it would imply that the fast progressors, that is these 4 types, could in principle be eliminated from the population. And it might be safe to start cervical cancer screening at a later age as long as the women had been vaccinated and the prevalence of these HPV types were there. So let me summarize. HPV causes several different cancers as well as genital warts and other diseases. The vaccine can prevent the benign, premalignant, and malignant diseases induced by the HPV types targeted by the vaccines. The prevention of the malignant diseases is inferred. The basis for that inference is exactly the same as what's used for cervical cancer screening, so I would say it's on a pretty firm basis. Second-generation vaccines with activity against a broader range of types should achieve an even greater reduction in HPV-associated disease, and the high immunogenicity of the vaccine implies it should be possible to induce long-term protection with fewer than 3 doses. Thank you very much for your attention. Love to hear your comments and questions.
Hi, thank you for your talk. I was around when you introduced this. I followed the political chaos going on with this. Quick question, and it's more your thoughts. Is the Affordable Health Care Act going to cover the immunizations for various ages? And do you hope that now that it's going to be covered and there's not the same media backlash there was when you first came out, do you hope there'll be more support and more people getting vaccinated?
So the United States has a very interesting way of organizing vaccination. We have a federally sponsored program called the Vaccines for Children program, the VCF, which provides about 40% of the vaccines to children under the age of 18. And the HPV vaccine is among the vaccines that are offered through the Vaccine for Children's program. And so children from poor families that are Medicaid eligible, and there are a number of other criteria, all can get the vaccine for free. It actually costs them less than it costs the children of people who have private insurance, because the private insurance doesn't always pay for the cost of the visit. They pay for the vaccine, but they don't always pay for the cost of the visit. In principle, with the Affordable Care Act, prevention costs are supposed to be fully covered. Whether that's going to be a big difference in this instance, I'm not sure. Most women get cervical cancer screening, and whether the Affordable Care Act, whether the Affordable Care Act will have a big impact on that, I don't really know. In principle, it means that any woman who wants to get screened should not need to pay for it. But it's hard to know. The women who, a high proportion of women who develop cervical cancer are women who have not been screened, and obviously lack of access is an issue. One would hope that there would be less, that it would be easier, but it remains to be seen.
You had commented before on the efficacy of screening, and we heard in Mr. Cantrell's case that maybe one of the earliest detections was due to his breath, and his wife could smell the difference. Could you comment on what research there may be for using odor as a form of detection for HPV and for very cost-effective screening?
I have no specific information about that. I can't comment on it.
I think that's a non-specific manifestation of head and neck cancer. It's just as common to have that in HPV negative as HPV positive, and it's because the bacteria that colonize our throats probably grow quite well on a tumor that doesn't have normal blood supply and immune defenses.
I just had two questions. One is, I think maybe the ratio for men to women is even higher today than 3 to 1 than it used to be. And I was just wondering, is prior vaginal cervical infection in any way protective, or is that a possible explanation to explain the difference? And then my second question was, now that we're vaccinating for high-risk types,
It's not mine.
I know, but have you noticed any shift in the screening for
So the answer to the first question is that we did studies actually back in the 90s that demonstrated that males had a much lower rate of being antibody positive than females, and we suspect that it is because of the genital infection in the women somehow leads to they're more likely to develop antibodies, which we take to be an index of immunity. And so I think it's certainly possible that immunity is somewhat protective and that women are more protected than men are. But this is speculation. Your second question really is one of HPV type replacement. And thus far, there is no evidence that there has been HPV type replacement. And my medical epidemiologic colleagues, their notion is that these viruses tend to behave relatively independently one from the other. But clearly, both companies are following up populations in Scandinavia for a minimum of 15 years and will be looking at that question. And in Costa Rica, we're also doing a long-term follow-up looking at that issue as well.
I had a quick question. Assuming there's no decrease in antibody titers or immunity, do you think a possible solution to the social backlash could be offering the vaccine maybe at a young age, like 3 or 4, just like we do with other vaccines?
Yeah, I mean, this is certainly a potentially viable possibility, but there currently are two problems with it. The first is that it would take that much longer before you would see an impact from the vaccine, and from a cost-effectiveness point of view, that might be a reduction. Okay. The second is that we haven't followed patients who have been vaccinated for long enough to know whether it would last long enough. What I think one could maybe more safely envision is maybe the first dose. If you were going to be doing 2 doses, you might give the first dose at that age, and then a booster dose as an adolescent. But again, you would get into the same social problems. You've been very patient.
2 quick questions.
It's your punishment for sitting in the back.
I'll sit closer next time. 2 quick questions. What do you know about the efficacy in women who are exposed to HPV 16 or 18 prior to getting the vaccine? Whether, I don't know if there's a way to know that.
So in Costa Rica, my colleagues looked at the natural history of the women who were vaccinated either with the GSK vaccine or with the control, which actually was a hepatitis A vaccine, and looked at the women who had prevalent infection at the time of vaccination. And there is no difference in the rate at which they clear. Okay, so there's no strong suggestion that there is a change in the natural history of people who are prevalently infected. Okay, and Merck has said the same thing, although I haven't seen it published in the same detail as with the GSK vaccine.
Men, older men receiving the vaccine, say between the ages of 20 and 30, what are your thoughts?
So the issue of the vaccine, the Merck vaccine is approved for males up through age 26, I guess, maybe 25 or 26. So above that age would be off-label. There are people who recommend it, if you will, as an off-label use, because when you look at the profile of the apparent age of acquisition of oral HPV infection, it looks as though many men are acquiring oral HPV when they are in their late 20s or even in their 30s. And so on that basis, it has been, it has been suggested.
So if newborns born of a mother who has HPV infection, I presume the newborns don't have antibody, do they? If they do, why don't newborns get the disease?
So the first point is that IgG antibodies do go across the placenta, and a proportion of the women have IgG antibodies. The second is that the incidence of genital HPV infection in pregnant women is very high, because it actually tends to go up because of the relative immune suppression of pregnancy. Probably you get reactivation, and after delivery, the percentage of HPV positivity in the genital tract actually goes down. But there is a potentially serious infection known as laryngeal papillomatosis, or recurrent respiratory papillomatosis, that occurs in children, and a reasonable proportion of those children are believed to acquire the infection during delivery through the birth canal. And one potential utility of the vaccine is that it should, at least for the Merck vaccine, it should virtually eliminate this disease. The problem is that it's not so much of a public health problem, because there were maybe 1,000 cases in the United States per year. And so it's difficult, to strongly advocate for that. In addition, it would be an off-label use of the vaccine to vaccinate for that reason. Of course, it's perfectly fine to vaccinate women who are not pregnant, who are of childbearing age. That's perfectly legitimate, but it's not an FDA-approved reason.
Are there any other questions?
Just based on vaccinating older men, the earlier comment, Moore Gilson's paper, right, in JAMA, they showed actually that there's those two peaks, actually, of oral infection. And the second one is actually more like in their 40s, right? And I just wonder if you don't get a strong immune response from sexual exposure.
This is a little bit of an inside baseball kind of discussion, but Maura Gillison and her colleagues had a paper looking at single time point prevalence, published in the Journal of the American Medical Association about 2 years ago, and what was shown was this biphasic curve, so that men who were like in their 50s had a higher incidence than men in their 40s, a higher prevalence than men who were in their 40s. I think that it remains to be seen whether this is attributable. There are several potential explanations. One is it's simply a cohort effect, you know, and if you had been able to sample those men who were in their 50s and you sampled them in their 40s, they would have been high then too. Another possibility is that it's actually reactivation of a former infection where you have had clinical resolution, but you were still virologically positive, you know, so that you now have a reactivation. And then the third possibility is a new exposure. Similar kinds of biphasic prevalences have been seen in some countries, and in women at the cervix, and you go through the same kinds of issues, and it really hasn't been resolved.
I have a quick question on HPV testing. A lot of the statistics are based on testing for positive or negative for HPV. And what do you think is the true positive and true negative, false positive and false negative testing for HPV, both genital as well as oral? What do we know about false positive and false negative testing?
So it may be a quick question. I'm not sure it's a quick answer. I think that first let's deal with genital infection. Okay, when Luba says false positive, what she doesn't mean you were HPV positive but you're not infected. She means you're HPV positive but you don't have precancer. Okay, let's just understand. The test is very specific in terms of detecting HPV. There are very few false positives in the sense that you're positive for the test, but you're not really infected. But there are many people who are infected but don't require treatment because, as I mentioned, the natural history for most infections is they just go away. You don't need to be treated. So this brings up the issue of false positive in that sense, and a lot of people are working on what are called ancillary tests. So one of the favorite ancillary tests is P16, which Dr. von Waes mentioned is positive in a very high proportion of HPV positive cancers, but also in a high proportion of HPV positive precancers. And so that's one possible test. Another test that is being examined is methylation. There is methylation of specific parts of the HPV genome, which seems to be predictive of whether or not you are going to have, whether or not you have premalignant disease. So those are the kinds of things in terms of false positives, what's being done with it. False negatives. The HPV-based testing is remarkably good at eliminating false negatives, as long as you have a valid test. That is some kind of DNA test. The DNA is really there in the test. There's almost nothing that happens in the next 10 years. Your chances of developing high-grade cervical dysplasia are very low. And this is one of the reasons why with co-testing, the recommendations now of the U.S. Preventive Services Task Force is every 5 years if you have cytology plus HPV testing. Whereas cytology alone is now only every 3 years. So that takes care of below the waist. Now, in the mouth, the prevalence of infection is much, much lower, and I think that there's just not been that much experience. People have, and I think the predictive value is just not that great. So in that sense, there would be a lot of false positives. One thing that I didn't mention is that there was a recent study with data in Europe using HPV-6 antibody as a serum test, and it seemed to be highly predictive of people who were destined to develop what are presumed to be HPV-positive oropharynx cancer. But more research needs to be done to try to look at those correlations, because a lot of them are inferential rather than strongly evidence-based. Thank you.
It's not behalf of all of us. I want to thank you both for your authority. Huh?